Let's discuss pathophysiology of PCOS today. So what is the main reason behind polycystic ovarian syndrome? What is the thing which is main derivative of all the problems which are happening in a patient with PCOS? That is chronic anovulation. So chronic anovulation is the main reason why the patient is suffering from all the problems. So disordered endocrine milieu that results from chronic anovulation is responsible for all the factors, which for all the things which are happening in a patient with PCOS. So first we will be seeing this graph diagram. So here you can see basically it is a pictorial diagram showing all the hormonal changes which happens in a patient with the with normal menstrual cycle. What happens in a normal menstrual cycle is, as the follicle recruitment starts, the pituitary releases FSH, and this FSH acts on the small follicles, antral follicle, and that leads to growth of antral follicle, formation of dominant follicle, which starts releasing estrogen. And when estrogen becomes reaches the threshold, that is what the threshold is, it reaches more than 200 picogram per ml, which stays in our body for more than 50 hours. That will lead to LH surge. Okay, this LH surge with violet one, that will lead to LH surge, and then that follicle will become corpus luteum, and that corpus luteum will secrete the progesterone, which if pregnancy happens is responsible for the support in the pregnancy, luteal phase support in the pregnancy. Okay, so this is what is happening in a normal woman when the ovulation is happening because of increase in FSH and LH surge. Okay, but what happens in a woman with polycystic ovarian syndrome? In those women, there is a steady state of hormone. The LH, the FSH, they are not released in a pulsed manner. Okay, so that's why, because the pulse, the frequency and the amplitude of LH and FSH are very important for the ovulation to happen, for the follicle recruitment to happen. So that is not happening in patients with polycystic ovarian syndrome. But there are other pathophysiological theories which have been put up, which we will be discussing about why PCOS happens. So this is only one of the theories which is based on the abnormal gonadotropins. So this is the first theory which says there is abnormal gonadotropin secretion and action. But there are other theories also, that is the abnormal insulin secretion and action. Third is abnormal weight and energy regulation, and fourth is abnormal androgen synthesis and action. So these are the different theories which have been put up regarding the pathophysiology of PCOS, what leads to PCOS. So first, one by one we will be discussing. First is abnormal gonadotropin secretion and action. In patients with PCOS, it is seen that there is increased serum LH concentration. So if you see the hormonal profile of the patient with polycystic ovarian syndrome, there will be mismatch between the LH and FSH. Usually LH and FSH runs together. FSH is slightly more than LH in under normal conditions. But in patients with PCOS, it is seen that LH concentrations are much higher when compared to FSH. Rather, FSH is on the lower normal side. Either it is low or it is normal. Okay, so I'll be telling you why it is low or normal, so that I will be telling you. But first, what is this LH? LH is luteinizing hormone which is being secreted by pituitary. Okay, so what happens to LH in a woman with PCOS? There is abnormal LH secretory dynamics. Okay, so LH secretory dynamics is altered. There is increased LH pulse frequency and amplitude. Okay, and the LH which is being produced is more bioactive as compared to the LH which is being produced in a woman who do not suffer from PCOS. Now coming on to why the FSH levels are low in the woman with PCOS. So there are two reasons for that, because of the chronically elevated estrogen levels and the increased inhibin B, which is derived from small follicles. Okay, so those small follicles will release inhibin B, which will have negative feedback effect, and the estrogen also will have negative feedback effect that will lead to decrease in FSH levels. So that's why the PCOS women will have lower FSH level when compared to the normal women. Okay, so that's why there is this alteration of LH to FSH ratios. Second is abnormal insulin secretion and action. This already we have discussed in our last video, how insulin is responsible for hyperinsulinemia leads to hyperandrogenemia. This already we have discussed. We discussed this insulin resistance. What is insulin resistance? Which is again I'll be just briefing. It is a condition in which endogenous or exogenously administered insulin has less than normal effect on fat, muscle and liver. Okay, so what is insulin? Insulin is the most important anabolic hormone which our body is producing, which is being produced in the pancreas. So it is the most important anabolic hormone. What is meant by anabolism? Anabolism means the construction. Okay, anabolism is construction, catabolism is destruction. Okay, so what is what anabolic effect insulin has on fat? It leads to lipogenesis. Okay, it inhibits lipolysis, it leads to lipogenesis. In the muscle, it is responsible for GLUT4 expression and it leads to uptake of the glucose. And in the liver, it leads to glycogenesis. It inhibits the glucose production, leads to the storage, it leads to the glycogenesis. Okay, so these are the conditions, these are the things which insulin does. Insulin resistance means the body is not responding to insulin. Then what will happen? In the fat, because lipogenesis is not happening, it will lead to lipolysis. In muscle, the glucose will not be able, the GLUT4 receptors are not able to uptake the glucose. In the liver, the glycogenesis won't happen. Rather, there will be increased glycolysis. Okay, so that is what happens when there is insulin resistance. So this already we have discussed how hyperinsulinemia leads to hyperandrogenemia. The hyperinsulinemia, it increases insulin-like growth factor 1, decreases insulin-like growth factor binding protein, which in turn leads to increased IGF-1. It decreases SHBG, which in turn leads to increased androgen, the testosterone. And this IGF is which is responsible for theca cell stimulation, ultimately leading to increased androgen levels. These all things we have discussed in our previous video. The insulin is responsible for tyrosine phosphorylation, but in PCOS women there is serine phosphorylation instead of tyrosine phosphorylation, and because the tyrosine phosphorylation is not happening, so the metabolic pathway of the insulin, which is mediated through insulin, the metabolic pathway, it is getting inhibited. Okay, so this AKT, which is the major effector molecule playing role in signal transduction, so all those things are not happening. There will be more glycolysis, as I already explained. There will be more lipolysis because insulin is now not acting as an anabolic hormone, rather a catabolic hormone. Okay, so these all things we have discussed. You can see our previous video. Then coming on to abnormal weight and energy regulation. PCOS women have, as we all always have seen, the category of obese PCOS patient. If we categorize the PCOS, there are two kinds. One is lean PCOS and one is the obese PCOS. 80% of the PCOS patients are obese and 20% are lean. Even in the lean patients, if we see the abdominal circumference, it will exceed as compared to the patients who do not suffer from PCOS. Okay, so how these weight leads to problems in these patients? The PCOS patients are seen to have android obesity, and android obesity is the one which is more associated with insulin resistance. Okay, it is the android obesity which is more related to insulin resistance. The visceral fat is more active metabolically than the subcutaneous fat. Okay, so anything which is more metabolically active is more sensitive to it is more sensitive to lipolysis. So whenever there is more lipolysis, there is more free fatty acid production. Again, I will just once show you this, which we have already discussed. Increased free fatty acids will lead to increased serine phosphorylation. Increased free fatty acid will lead to stimulation of 1720 lyase, which is responsible for production of all the androgens. So the patients who have android obesity will have more lipolysis, more free fatty acid, more serine phosphorylation, and thus inhibition of insulin signaling. Okay, so PCOS patients have leptin resistance and lipotoxicity. So are PCOS patients more predisposed to obesity? This is a question which many PCOS women ask. that am I supposed to gain more weight when I am compared with my counterparts. So what happens in PCOS women, there is something known as postprandial thermogenesis. This postprandial thermogenesis is there, which is decreased in women with PCOS. Whenever we have food intake, our body, the insulin secretion happens, and that leads to thermogenesis in our body, so that we metabolize the food which we have taken. So these women will have postprandial thermogenesis, which is decreased in PCOS patients. Resting energy expenditure appears to be equivalent to that of normal weight matched control, but because the postprandial thermogenesis is decreased in these patients, so that leads to weight put on in these patients. There is impaired conversion of lipid to carbohydrate or protein. Okay, so whatever there is the more conversion of the lipid to carbohydrate and protein, all these things are not happening, so they are more prone to weight put on as compared to normal counterparts. And there is more tendency to accumulate abdominal fat, with weight gain leading to greater waist to hip ratio than BMI matched normal women. So even if the woman is lean PCOS, it is seen that the PCOS patients will have more abdominal fat, and that leads to their increased waist to hip ratio. Okay, so that particular thing is known as android obesity, and it is the android obesity which is more associated with, as I already told you, more associated with insulin resistance. Okay, so fourth and the last pathophysiology is androgen synthesis and action. Okay, so there are abnormal LH secretory dynamics. As already we told, there are abnormal LH secretory dynamics, means, again I'm repeating, there will be abnormal increased LH pulse frequency, amplitude, and the LH which is being produced is more bioactive. Okay, and then there is hyperinsulinemia that leads to increased androgen by what we already explained. It is increased IGF and IGF binding protein, which is leading to hyperinsulinemia, and which is leading to hyperandrogenemia. Okay, there is intrinsic dysregulation of key steroidogenic enzymes. Already I have explained, there is increased 1720 lyase activity, which is in turn producing more DHEA, which is producing more androstenedione and more testosterone. There is decreased 3-beta hydroxysteroid dehydrogenase and increased 17-hydroxylase. So these are all the pathophysiology, these are all things which are associated with pathophysiology of PCOS. So all are the factors which more or less contribute to the to all this metabolic pathway, all this metabolic syndrome which is happening in patients with PCOS. I hope I could clarify some of the pathophysiological things which are associated with PCOS. Thank you.